When we get there, what happens? Is it stuck or is it painful?
It feels stuck.
Okay, if I give you some help.
Yep. Perfect.
Good. And this is 2 fingers. We're not giving you a ton of pressure.
I know.
So it's getting better. Go ahead and let them come back down.
When it gets to that point, it pops.
Up here.
Yeah.
Popping. Popping's okay. There's a lot of swelling inside that shoulder, especially after how severe that shoulder replacement is. There's going to be swelling in there for 6 to 12 months, and it's going to be very variable, especially when we're getting back to different activities. It's going to swell some, and then we take it easy, or we ice, or we do some gentle movements. Swelling's going to come down. Popping and noise is okay. Painful popping is not something we want.
No, it's not painful.
But if it's just noisy, that's normal.
Yeah.
This is Sara, and she has right SI joint pain that she's had for quite a while. It's related to her job of being a softball coach. So she has right SI joint pain. And it is aggravated when you swing the bat, and specifically during like batting practice, where she would be hitting at her players.
So Cindy is a 66-year-old female with a 7 weeks post-op lateral knee arthroplasty. Go ahead and relax for me. So everything's moving super well. That tibia has great transverse plane mobility. We can check that sagittal plane. That all feel okay? How's that fibular head? That was a little tender for a while.
Yeah, it's
feeling
okay.
better?
It's okay, it's better.
Better? Good, okay. Those incisions, still a little bit pocket. Man, it looks so much better though. That looks so much better than it was.
So this is Aida, and she is here because she has gone through breast cancer diagnosis and a right mastectomy. She also had radiation. How many sessions of radiation again?
33 days.
33 days of radiation. So radiation is generally Monday through Friday. With
15, 20 minutes, yeah.
Yep, 15 to 20 minute sessions Monday through Friday for about the 30 some odd sessions.
Days,
Yep. And then now she is experiencing, we've treated her in the past for some of the residual scar tissue and radiation fibrosis directly related to the chest wall. Now she's kind of coming back to me because her pain and discomfort is kind of creeping up into her neck on the right.
Thumbs out to the side again, raising out, out, out. Good, remember we're keeping that shoulder down. No cheating it. Is this one tougher?
Yes.
Okay, coming up as high as you can. Stuck or painful?
Stuck.
Okay, I'm gonna help you again. Good, we've got the motion. Now we're still hiking that upper trap a little bit too, so make sure.
It feels really tight now.
I know. Especially when we're practicing in the mirror or doing your home exercise, make sure you're keeping that shoulder down, because this is that one that was giving you all the trouble. After we did the dry needling last time, I know it felt a lot better, but I want to make sure that that's not just coming back. We can do the needling again in the future, but if it's given all that pain and pressure, I don't want to have to do that over and over again if we can just keep it from getting there. Plus, as soon as we get to the point where that shoulder's doing really well, if you've learned that pattern of movement, that every time you raise your arm, you pull that shoulder up, it's never going to go away. The surgery is going to do great, but this upper trap is going to stay angry. Headaches, pain with sleeping, all that stuff. So let's lay on your back and work on your shoulder a little bit. So Lisa, do you want to give them a little bit of information about what happened to you? Tell me about your shoulder, tell me about what happened in surgery, all that stuff.
How it got bad?
Yeah, just how long were you dealing with shoulder pain? And
I had, I was doing kettlebell flies, and I had a torn rotator cuff. And I couldn't plank because my shoulder was just tremoring. And then from there, the pain just got severe. It was probably about 3 to 4 years after I knew that I had the torn rotator cuff, and then it just started getting worse. Finally, I just said, I have to really get surgery. So I went to the surgeon, and he said I could get a replacement or have it fixed. So he said the best thing to do was to just have a full replacement, because I had arthritis, and I was bone on bone, and I also had bone spurs. And that's really where the pain was coming from. So I agreed to have surgery, and that was on December 14th. So
8 weeks, 9 weeks?
Yeah, 9 weeks. 9 weeks out.
So total shoulder replacement is a very intense surgery. something where they're dislocating the humerus. They reflect the subscapularis, so cut its distal attachment to expose the humeral head. They're going to take a burr tool to remove the humeral head. They're going to stretch the internal medullary cavity of the humerus with these different sized rods that are going to open up the medullary cavity. And it's really grisly. If you haven't seen a video, go watch it. If you haven't seen a video, don't watch it.
Yeah, really. For sure.
Because it's like I went through that, but you were asleep, which is good. And then they're going to resurface the glenoid with a different components, but resurface the glenoid, resurface the humerus, reattach the subscapularis, and get out of there. It's a pretty quick surgery, but the level of intensity and damage to the shoulder while they're working through it is what gives the patient so much pain afterwards. The surgery itself is great. They'll range the shoulder right afterwards. Things move excellent. But the extent of the surgical invasion leaves them reeling for a while. So 4 to 6 weeks is typical to be in a sling. Lisa went through that process more begrudgingly than willingly. Was kind of fighting the urge to be out of the sling and use her muscles. It slows down our progress a little bit, but it keeps other structures moving well. So when we have that surgery initially, like I said, the shoulder's moving great, but the muscles around it are going to be painful. But there's nothing wrong with the elbow. There's nothing wrong with the wrist. There's nothing wrong with the thoracic spine or most of the scapula other than the glenoid. And so when we get to these patients early on, the main focus is retaining all of that motion. We don't want to allow the specific glenohumeral joint losing motion to cause loss of motion in all of these other joints. So a lot of passive range of motion activities, things that aren't going to utilize the rotator cuff musculature, because again, they reflected that subscapularis and remove that distal tendon. So to use the rotator cuff is going to cause a lot of pain early on. And that's where a lot of her pain came from initially. Now the body's developed this compensatory pattern where if the rotator cuff is not functioning well, we will over-recruit the upper trap. So upper trap is a very common tender point or trigger point in the shoulder after this type of surgery, and it's a big concern for us to not only make sure that Lisa can sleep at night, but that she's not relearning that pattern. That's why when we were talking about her motion just a moment ago, really talking about keep that shoulder down, we need to be reaching and moving with the actual shoulder versus hiking up that shoulder blade and over-recruiting that upper trap. Lisa and I did some dry needling last week or maybe the week prior. Did some dry needling to that upper trap and released a lot of that tension by overcoming that muscle's ability to contract, overstimulating it with electrical stimulation, and getting it to the point where it's been much, much better since then. But we don't want to have to do that all the time so that she's dealing with this upper trap pain. How's this pressure feeling here?
Good.
So first thing I want to work on when I've got a patient at this stage, 8 or 9 weeks, we're in the active range of motion but not strengthening phase. I want to allow her to explore that motion and use these muscles, but we're not ready to put resistance through them. So first thing I need to do is calm down the irritated structures like the upper trap so that when she goes to move, it's not the first thing to jump, so she can actually isolate the rotator cuff and start to strengthen it effectively. Other things I've really been focusing on are making sure that her scapular mobility is still there. A large portion of glenohumeral motion means that the scapula needs to upwardly rotate, it needs to be able to adduct and abduct, it needs to be able to elevate and depress. And so since she's not been doing any of that stuff because it was painful, I've been doing it for her. So in this position, I can take the patient's arm. Lisa, I want you to let this just kind of rest. Good. I can take the weight of the patient's arm, grip right here at the medial border of the scapula, and just give some stretching through these muscles. And range it in all kinds of different directions. We can go in cardinal planes, we can go up, down, or superior, inferior, we can go medial and lateral, get some gliding here. But our body doesn't really move in unidirectional patterns. I want to make sure that I'm adding some three-dimensional movements. I'm not only giving a superior glide, but also an upwards rotation. I'm giving her some abduction and internal rotation. giving her some scapular depression, making sure I'm stretching that upper trap a little bit. How's this feel, Lisa? Okay?
Yeah.
Good. This is her favorite.
Yep.
He loves when we take that shoulder blade. So I've got it gripped at medial border, at lateral border, and right at the spine of the scapula. And I can move that pretty much any direction I want, as long as she's relaxed. How's work been?
Good.
Feel like you're getting a little bit more tolerant to it?
Oh, yeah.
Good. So going back to work is almost always going to trigger some sort of increase in pain or soreness, not because they're getting worse, but because their activity levels change immensely. When we're at home recovering from surgery, you can be focusing on doing what you need to do and doing your exercises and icing and keeping your hydration up. When we get back to work, whether you're a desk job or in retail or manual labor, it makes it much more difficult to focus on what your body might need at the time, and instead you're a little more focused on what you might need for the job. And so I try to prepare all my patients that when you go back to work, it's not abnormal for you to feel a little bit worse for a while, but your body will catch up. It'll get used to it, but give it a couple of weeks. Are we at that point yet?
We're at 2 weeks.
Okay. Does it feel like it's kind of getting
Better.
better? Okay. What do you feel at the end of the day?
I'm not really sure because I'm very conscious of what I'm doing at work. Like I'm not hanging apparel or anything like that.
Sure.
I'm not doing displays.
Okay.
I'm just pretty much ringing up at the register.
Okay. Still trying to use that shoulder when you can, right?
Yes.
Good. A big part of what we do is not only putting our hands on patients, it's helpful, but we need to make sure that we're pushing her outside of here and during her exercises in here. Because I see her 3 times a week. That's 3 hours total in the week, and there's 168 hours in the week. So for 165 hours, she's the steward of this shoulder, and I can get a lot done in 3 hours, but we can get a lot more done in 168 hours. When we're training these movements, we're providing active movement in both. She's going to feel what it feels like in this shoulder, and it's going to feel different on this side. So she will just naturally try to make them feel more similar. Thumbs upwards. I want you to reach up, up, up overhead. I'm just guiding the motion at this point. We used to have to give her some pressure, not too much anymore. I do want you to keep your arm a little bit more close to your ear. Good. What do you feel here?
Yeah, more. Whoa, whoa, whoa.
We're working, okay. Come back up. 5 times, please. Up, up, up. Reach, reach, reach. Relax that upper shoulder. Good. Now, if I don't even help with this one, Lisa, I want you to take it up overhead on your own.
It's gonna pop.
It might pop. Popping's okay.
I wish it would pop. Because it hurts when
We don't want to force it to. If it does, it's okay. Go ahead and raise your body up overhead. So we saw when she was standing trying to raise those shoulders, she really got stalled out about here, about 90, 95 degrees. When she gets to here, gravity's actually assisting on the way down. So she has a lot more range of motion. Even though this is active range, I don't have to push it. By manipulating gravity and putting her in a position where it's helping her get her arm overhead, it helps us a lot. Bring him back up. But I want to play too, so I want to give some pressure. Reach, reach, reach. Breathe. And back. One more. Up overhead. Reach, reach, reach. Good. Reach for the, not the sky, I guess, but reach over your head like you're trying to reach up, up, up. Good. Working the scapular kinematics into the shoulder. We need to have both. Breathe. Good. And back. It's harder to tell when patients are breathing now with our masks, but there's usually a little bit of pinkness that comes to the face. Kind of gives it away. Let your arm just relax. Good. Last thing I'm going to do with Lisa is do a little bit of shoulder mobilization. So even though they've done a joint replacement, there's going to be a lot of intracapsular swelling. Inside of that joint capsule, it's going to be puffed up. And if I can give a little bit of pressure to that glenohumeral capsule by gapping that space, gapping the humerus and the glenoid a little bit, it's going to allow for just a little extra space and a little bit more fluid circulation so that she doesn't feel that tightness when she stands back up. I'm gripping at the elbow here, pulling along the long axis of the humerus, giving a little bit of an inferior glide at the shoulder. So gripping at the elbow, pulling down, and a little bit of an inferior glide.
And Lisa likes this too.
Lisa likes this too. Lisa likes pretty much everything about therapy, which makes Lisa fun to work with. Total shoulder is one of the most painful surgeries that we see, and so it's really helpful to do some things that both focus on recovery and motion, but are also focusing on just helping them feel a little bit better. The first 3 or 4 weeks, you don't get more than an hour to a night of sleep because pain is going to be waking you up, or you can't even fall asleep because it's so painful. Doing some things to just make them feel better and give them a good ability to heal, good sleep, good fluid, good hydration, good food, all of that stuff makes a big difference. And we get to talk to the patient every other day. The surgeon gets to see him at 2 weeks, at 6 weeks, at 3 months. So we get to check in a lot more frequently and make sure she's doing all those things that are taking care of herself on a daily basis. Feeling good here still?
Yeah.
With this exercise, I want you to take this stick, and again, we're trying to tie your right arm and your left arm together because I don't want you to have this big difference in movement by the time we're done. So with the right arm and left arm moving together, keeping that shoulder down, I want you to take this stick as far into the clinic as you can. Good. No pressure added. She's able to take that arm up. Now I'm looking visually for any differences, so if we get over top of her, we can see that that right arm is a little bit more abducted than the left side. It's in a little bit more of a scaption position, which is a blend of abduction and flexion. She's fixing it now because I said something, but this arm was kind of pulled out to the side compared to that one. And so we want to make sure that things match. When we have a difference in the way left side and right side works, it almost always will eventually result in some sort of dysfunction. Over time, if you've got a lot stronger left side than your right side or a lot tighter left side than your right side, eventually the body will work past that dysfunction and build some sort of compensation, and that's when I'm seeing patients in for, I don't know where it came from, it just kind of came out of nowhere. We need to make sure we catch that stuff early, otherwise she's going to come in with right-sided neck pain a year from now and go, my shoulder's fantastic, my neck is killing me. And her neck's killing her because I didn't catch that stuff early on. Look at all that motion.
I know, it's good, huh?
It is good. Hey, this is Katie, my technician. She's going to take you through your exercises today.
I'm good. How are you?
While she's taking you through these exercises, remember, nothing should be painful. So if you're starting to feel pain, especially in that upper trap or in that shoulder, you let myself or Katie know. If it's uncomfortable, or you feel like you're stretching or it's challenging, that's fine, but pushing through pain is just going to find us more pain. Katie, Lisa's been doing really well. We're, I think, 8.5 weeks, give or take a couple days outside of her shoulder replacement.
Okay.
Main thing I really want her to focus on is keeping that upper trap down when she's getting her motion back.
Gotcha.
Motion's doing way better, but she's starting to keep that compensatory recruitment where she's lifting it up. So make sure that you're using those lower traps. Make sure you're triggering her to use the right muscles to overcome that muscle. In about 3 more weeks, we're going to start her strengthening stuff, and that's kind of the final phase. 12 weeks post-op is when we can start really working on, I want to lift things, I want to push things, I want to pull things. We'll get there, but let's focus on motion first, okay?
Okay.
All right, you guys ready?
Yep.
All right, here you go.
Woo.
This is Sara, and she has right SI joint pain that she's had for quite a while. It's related to her job of being a softball coach. So she has right SI joint pain, and it is aggravated when you swing the bat, and specifically during like batting practice, where she would be hitting at her players how many times in a session?
It's like 400 to 500 if it's like a full defense day.
So that's a lot of swings.
Yeah.
And it happens back through here, especially when she does her wind up. Any issues on the follow through?
I would say so. More like at contact, as like everything, all the power's coming through.
Okay.
That I'll feel it on the right side.
All right, and anything else in your daily routine that would bother with the SI?
Sometimes with like bending over and picking stuff up. Sometimes like if it's irritated after softball, I'll notice it just standing there. But mostly like picking stuff up or hitting.
Okay, and no injuries, nothing like that she knows of. This is just overtime, repetitive. So overtime and repetitive means we know that it is probably a breakdown in the mechanics through her whole chain and not just at her low back. The SI joint is probably just the symptomatic site of where her pain is, so then we have to look elsewhere is causing her symptoms. So we need to look at her stance when she does her backswing, and then just generally look at thoracic mobility, hip mobility, and kind of how everything works together. So I would always do the basic, watch her walk, check range of motion and strength, but what we're gonna look at is more of the sport specific and some of the more like chain type movements, because I think those are the big hitters of what we need to treat anyways. And she has a history of an ankle sprain and ankle injuries that is relevant, but we're gonna focus more on the low back today. Okay, so first I want you to stand up for me.
Okay.
And let's first do some bigger movement stuff like a 3D maps. Okay, so Sarah's gonna mimic what I do, and we're just gonna kind of look at global movement. So first I want you to kind of go the forward chain one.
Backwards too.
Yep. Good, do about 5 of those on each leg. So this is where I would kind of walk around and just kind of see how everything looks, see how she moves through her low back, and how she loads, and then depending on which foot is forward. Good. So for her, she doesn't get a lot of extension through her thoracic spine. So we know that her thoracic spine might be kind of stiff, kind of important when she goes to do her backswing. Good. Now let's do yep, that one. Good. So this one kind of looks at how the hips move with the upper body in the frontal plane. Good, and she has a little more trouble moving to the right. Now let's switch legs. Are you having any, does this provoke any of your symptoms?
Not so far.
So luckily with Sara, she doesn't have a lot of general pain. Her pain is not on a high severity level. It's more of that chronic, low level, annoying pain that we know since she's young down the road we have to get taken care of. It doesn't really stop you from doing the things you want to do.
No.
She's able to just kind of push through it. And then let's do the rotation. Good. So I'm going to watch this one from behind. Since this one is kind of similar to rotating with her wind-up, I'm going to compare the two sides. Good. Let's see the other side.
Maybe like a little.
When you go back,
This way.
okay.
No.
Good. And then one more time on the other side.
Yeah, like right at the back.
Good. So she is not able to step back and rotate and open up as far on the right side as she is on the left. So that tells me some hip limitation with rotation. And then we already saw the thoracic mobility restrictions above. So for you, we would need to focus on some thoracic rotation and then hip rotation. Now I want you, let's look at core strength and her ability to load. We know that with swinging sports, anything that requires power, the backswing is going to be where she really loads her muscles and her core so that she can lead with her trunk and power through. So I want you to get into the swing. Now hold. And we're going to see what happens when she gets a little force pushed into her. So hold there, don't let me move you. So we throw her off a little bit.
Dang, that's not good.
It's okay. So that early, I'm not putting very much force through her, and you can see that she's losing some stability. Now let's do your swing through.
Okay.
Same thing. She would have ball contact there, so I'm going to go from this direction. She's a lot stronger, loaded, and rotated through this way. Good. Now I want you to do your position at contact.
Okay.
So this would be where She also gets some back pain where the ball would contact the bat. Hold there, don't let me move you. Stability was pretty tough there. So we know that her ability to stabilize through her core is limited, probably also a little bit through the feet. So we'll have to do some core strengthening and recruitment. It tells me that she is getting more muscle activity out of her global movers and less out of her deep core stabilizers, like the multifidi in her back, transverse abdominis in the core. So that is something that we need to retrain her stabilizers to fire first instead of her movers. Let's do another good core assessment it's called the lumbar protective mechanism. I'm gonna have you stagger your feet. I'm gonna stand in her stagger. It's very similar to what we just did. Don't let me move you. And I'm grading kind of how much pressure I'm putting through her. Right there is where her core breaks. It's probably like a 2 out of 5. And then I'll have you switch. Hold again, don't let me move you. That's tough. Which one feels tougher?
I think this one feels tougher.
I think this one feels tougher too.
I feel like I didn't do anything.
One more time. You're way more solid when your left foot is back and your right foot is forward, so switch. And that is a little bit of that stance for swinging as well. So it tells me something definitely going on her right side, which is her painful side. I'm gonna put Sara face down and look at her hip and pelvic mobility a little bit. If I had all the time in the world, I would also look at her neck range of motion because she needs to have full cervical rotation with the batting. And then I would also look at the ankle mobility because swinging is like the best head to toe motion. She gets motion from her neck all the way down to her ankles. I'm gonna bring your sweater up. So first, what I'm gonna be looking for is what happens at the sacrum and mobility through here, also combined with hip mobility, because we know that she's getting a lot of rotation through her pelvis. The right side's the painful side. I'm gonna start on the left, and I'm just kind of feeling for restrictions. And so for right here, I feel that she has some hard end feel and restriction through external rotation on her left hip. And she gets some early rise of her pelvis. It really should happen more like over here, and she's getting it at about 20 degrees. Should also get a little bit of sacral mobility. Should be springy. It's pretty springy. It's actually a lot firmer on the right side. Does that reproduce any of your familiar pain?
Just a little bit.
So she gets some familiar pain provocation on that side with a PA joint mob to the sacrum on the right. And then I'm going to assess the same thing on the right side that I did on the left. And she gets some early rise of her pelvis. It's actually even quicker on the right. So we know that there's some hip external rotation restriction on the right that's probably putting increased irritation on her sacrum when she rotates. And she goes through that rotational movement through the wind up to the follow through with her batting swing. So let's see if we can get a little more range of motion quick. So what we'll do is we'll do a little resisted contract relax. So hold there, don't let me move you, Sara. Hold. Good, and relax. Good. So I just go until, so when you do the contract, relax, and hold, it frees up some range of motion, and then you just go to the next restriction. Hold again. Good, and relax. You can see that we're getting a little more mobility because I'm blocking the early rise here. Hold again. Good, and relax. Good, hold again. So since we're gaining range of motion, good, and relax, then we have to then retrain it, teach the brain that it has new range of motion. Hold there, and I'm going to reverse my direction, so don't let me move you the other direction. So we're going to hold internal rotation. Good, relax. Gaining external. So you kind of use the contract, relax of the opposite motions to gain more range of motion. If she was right there when she started to get the early pelvic rise, her pelvis doesn't pop up until about right there now. So she's like, that's a pretty good improvement. Does that bother up here?
Just a little bit.
Okay.
No more than before.
Okay, good. And then we could do the same thing to get a little more mobility through the sacrum. We can use that contract, relax, and hip range of motion to get more mobility there. All right, you can sit up. Do one more thing in sitting for thoracic mobility. You can sit and face there. I'm gonna have you cross your arms over your chest. Okay, so first I'm gonna move you and see how it feels myself. I'm feeling for restriction. If you can see, I don't know if you can see it might be more from the front, but you can see that she has some mobility. Right there is where I feel the stiffness of the end feel, versus over here, she can get a little bit further. Again, that is her backswing. Okay, so what I want you to do is keep here. I want you to move towards me. Good, hold there. Don't let me move you. So we're gonna do a little contract, relax. Good, and relax. Move into it a little bit further. Hold there, don't let me move you. Good, relax. Hold there, don't let me move you.
It's super hard.
I know. It is really hard. That's at the,
I feel like I have my cords not doing
well, and
any
this
of it.
is where you are getting a little new range of motion, and so your body doesn't really know what to do with it. So that's where we have to re-educate. And I think that's a piece that gets missed a lot in therapy is you help someone move more or better than they were before, and then they don't get properly retrained in that new range of motion. And then you go have them do these like big crazy exercises, and their body doesn't know what to do. And that range of motion restriction will regress back to where it was in the beginning. So move again towards this way. Good. Now push into me. So teaching her body to recognize that she really does have the new mobility. Prolonged holds. You can see her muscles kind of shaking. That is her moving muscles fatiguing out and her deep stabilizers kicking in. Good job. Keep holding. You can see it's getting a little easier. Is it getting a little easier?
A little bit, yeah.
So the longer we hold, the better those muscles kick in, and she's getting more solid. I can't push her around as much. Good. Should we retest your batting stance quick? And then we'll do a couple, like what we would do for your home program.
Okay.
So do your batting stance. We're gonna retest. We're hoping she's a lot more stable. Feels a little bit better. I think it's a little bit better. One more time. And you can see, giving her about the same amount of force, and she's not as off balance. Cool. All right, we'll do a couple exercises. So lie on your back, and I'm gonna show you like a good warm-up core strengthening to get your deep core muscles firing. Everyone hates this one because it's difficult, but it's good. So drop your feet, hands on your knees. And your motion's gonna be push your legs down, but also push your knees up. And then you're gonna, lift your head a little bit, and you're gonna hold. You can see the muscles firing really good. Those are the shaking are her mover muscles, like the six-pack rectus abdominis, her SCMs, and her hip flexors. And she's gonna hold till fatigue, and all of those will kind of settle down, and her transverse abdominis, her multifidi in her back will start firing, the deeper core stabilizers. Might have to take a few reps to get to the good stabilizing part. It's settling down though, Sarah. You're doing a good job. You can see as the muscles are kind of settling and she's getting more stable, that's the deep core ones firing better. This is a good like warm-up exercise to like prep your core to fire first. Good job. And I would have her maybe repeat that 2 more times. And that'd be like the first exercise she starts with is like a warm-up. Since we saw that Sara had some thoracic restrictions, we are going to work on something for her upper back mobility. This would also be a good one for her warm-up before she hits. So she's working this one to work the sagittal plane. We could even add like a step in for her to get a little more global movement. So working the mobility, but also like preparing her body and her joints to work. The extension loads her core. Good. Now let's add the frontal plane. Let's do the other one, sorry. So you want to face that way. There you go. Good. Let's do a little wider stance. Good. So then she can even get some hip motion in there and work her hip mobility, because we know that she was lacking some hip mobility with upper body top down driving with her batting swing. Good. And then let's do a step and rotate. Good. Again, we can use the top down driver of her upper body on her lower body to drive hip, foot and ankle mobility, but also working on the thoracic. Good. And then let's rotate the other direction. Good. This is working on core strength, endurance, and then we're going to add some pelvic motion in with it. So I want you to go forward and back. So we're adding in some pelvic and hip drivers. And we're going to add in the 3 planes of motion: sagittal, frontal, and transverse. Good. And then we're going to add the frontal plane. Good. So this is a good, I like to do exercises that combine like multiple joint motions. It's like efficient use of time too for patients. Good. And then let's add in your transverse. Good. Good job, Sara. And so she doesn't really have any pain with any of the stuff we're doing, and so it lets us, it's a lot easier to let us work through some of this stuff. It's good. So I would give all 3 of those for the home program, and kind of like a warm up to playing. Cool.
So Cindy is a 66-year-old female with a 7 weeks post-op lateral knee arthroplasty. Go ahead and relax for me. So everything's moving super well. That tibia has great transverse plane mobility. We can check that sagittal plane. That all feel okay? How's that fibular head? That was a little tender for a while.
Yeah, it's
feeling
okay.
better?
It's okay. It's better.
Better? Good, okay. Those incisions, still a little bit pocket. Man, it looks so much better though. That looks so much better than it was. Okay.
It isn't a quarter anymore.
Yeah, it's just a very little bit. All right, so what I'm gonna do is I'm gonna start with some A-stem to her leg. Just deal with any fluid and fibrosis, kind of hit the knee into the quad. See how this feels. This will help pick up any like scar tissue fibrosis through the tissue.
No, more on the right side.
All right. All right, let me know how this feels. Is that all right? That's not bad at all. That's really not bad. You can kind of see how, remember how the lateral, we had that real tight like muscle? So you can kind of see how it's a little bit more, it's kind of lighting up a little bit more laterally.
Right. And then on the inside it would be sore, but it's not sore anymore either.
Yeah, well, we did a good job on that. Do you? I mean, that was the first thing we attacked. So her adductors were just like hypertonic, just super firing. They were so tight, trying to stabilize after that knee surgery. We really hit that medial hamstring and adductor, and now they're fine. I mean, we don't even really stretch it anymore, do we? We don't really have to.
You know, that's true. That's true.
So again, just working through, and you can kind of see, how it's kind of turning a little bit red versus there's nothing on the inside. There's a little bit of fibrosis in there. I want to make sure that, so what this does is it applies a shearing effect through the tissue. Healthy tissue with a shearing force, capillary beds don't break. That's the theory of it. But unhealthy tissue that's dysfunctional, the capillary beds will kind of rupture and you get a little bit of, again, bruising like that. So again, it's just a way to deal with fluid, deal with fibrosis, kind of get everything moving. I mean, to be expected. It looks awesome. You can kind of hit some of these things down here, make sure we're feeling okay through here. Kind of get around that incision a little bit. Again, just putting stresses around that incision through the tendons, making sure that they're doing okay. And yeah, we can kind of see just how we lit up on that lateral side. So we're going to keep hitting it. And again, it was a lateral replacement. We had lateral issues before, to be expected. And I can even come through and I can kind of feel, so you kind of feel a little more tightness through there.
Right.
Yep, so work through it. So again, Cindy's motion is awesome. Biggest things we've worked on are full knee extension, which we have, full knee extension during gait, which we're working on, right? That's more of a re-ed piece, not a mobility piece. Again, we're super close, we're coming. We're like 90 plus, 98% there. Knee flexion motion, relax for me. Relax, relax, there you go. Knee flexion motion, what did we get, 123 last time? And again, we have all the time in the world just to keep getting an extra degree or two here or there. Just working getting it symmetrical, but functional is 120.
I worked at home on the flex on
Did you?
my foot. Yeah, to get
Good. Incisions moving. Ooh, we even got a little couple pops there. Again, just more fibrosis, more scar tissue. Again, overall, really good. What I like to do is we kind of assess how the incision's moving by seeing how well it kind of pulls up and doesn't dimple. As you can see, we have it fully comes up, little bit of dimpling down there, but it also moves medial and lateral very well. That means it's not adhered, right? You have layers of skin, adipose tissue, fascia. So this one was stuck. It was like a dimple like that when we pull it up, and we got it to kind of pop a little bit. We'll hit those too with the cups. But overall, super, super good. Just want to make sure that we're getting that good. Yeah, look at how good that's moving. So one thing that, you know, we kind of forget about is that incision is scarred down. It's going to limit your mobility.
right.
If it's attached to your patella,
Right.
right? It's not going to move. But we've done such a good job with that. You've done awesome. Okay, stomach for me. Let me do the same to the back. Let me hit that calf especially. And same thing. I know we have a little bit of lateral calf issues. We had a lot of medial hamstring issues, which we already kind of addressed. Feeling much, much better. But let's continue hitting it with the tools. See what our, you know, dysfunction, fibrosis looks like. How's that feel? Feels smooth. Man, so when you have dysfunctional tissue, it feels like a cobblestone road. You go, it feels like a washboard. And that's how you can kind of tell where there's some dysfunction. This feels just great. It's not even reacting. I mean, it's not even turning red. I mean, that's beautiful. That's awesome. Such a good job with that. I can only barely start to feel a little bit more dysfunction with a little bit smaller tool, kind of right through that medial column. Once I get outside, it's just easy. Right through there. And I mean, do you feel that? No? We're just a little bit tight through that medial calf, medial gastroc. Got a little trigger point in there. Again, not bad at all. Oh my goodness, so much better. Yep, so just whatever I can do to help promote, again, that fluid return. Make sure tissues are not guarding, they're nice and loose. We've gotten so much stronger, so especially post-op is you have that big trauma to the knee. All the surrounding musculature just like tightens up and tries to stabilize. And generally it's gonna be really weak, right, because it's post-surgical. So muscles are tight, they're weak, there's pain, there's spasm, there's fluid. So as we start, and she's just a strong person. As we get her working out, get that fluid pumped out, get that tissue moving a little bit better, get the strength up, it really just helps everything relax. To the point where, again, like this used to be ropes. Remember that rope, and that was holding your knee bent? Because we couldn't even straighten it, but now we're doing awesome. You're good. So what I'm looking for is, again, how much a contralateral side has. I mean, and I have that extra couple degrees of extension. We just got to use it, right? We just got to use it when we're walking. That's the hard part. Yeah, that's great. So making sure patella is moving appropriately. Again, we have nice medial lateral glide. We have a nice superior inferior. That's probably the biggest thing we want to work on, is making sure patella is gliding. There you go. Good. Awesome. How's that feel? Yeah. Yeah. Always a good test to go. Feels about the same as that side. Kind of doesn't move too much better, so that's great. I'm using this little silicone cup. What it does is it applies let's see if we can find a position where this will work. It applies, so I've already applied a shearing force through the tissue with my ASTEM tools. Now I'm applying a decompressive force. I'm trying to separate the layers, right? Skin, adipose tissue, superficial fascia, deep fascia. When you cut through, you go through all those layers so they scar up together so they don't slide and glide. So as we try to separate them to allow them to be able to slide on each other, that's how healthy tissue should work. Unhealthy tissue gets pinched and gets stuck and doesn't actually move. So that's great. And so even with that, I can kind of work on little mobilizations. Trying to get it moving. And this is the same thing that you'll see on the Olympian shoulders, right? The cupping that they do. Now I'm obviously not going to try to leave a big tentacle mark, a big octopus suction cup mark on her knee. I just want a little bit of blood flow through there. Try to separate those tissues, make sure that incision is moving. And as you can see, like, it's moving very well. It's not really adhered at all. Just that last little couple of fibrotic tissues that I want to make sure we get adequate glide and slide through. Her popliteus, so her popliteus just got wrecked. It was so tight, that little diagonal muscle crosses the back of the knee, undergoes a lot of trauma, and because it's behind the knee, it can affect not only our ability to bend and go through appropriate transverse plane biomechanics, but extend as well, because it'll just get super shortened. And so this feels a lot better.
Yeah, I don't feel it. I feel a little tiny.
Just a little bit of tightness, yeah. Yeah, and again, so we know the knee has to go through, the knee's not just a single plane joint, right? The knee's a triplane joint, including transverse plane and frontal plane. And the popliteus is a very big transverse plane muscle that, goes from, that connects different bones. So we had to make sure that this unlocked to allow tibia to transverse plane, to rotate in the transverse plane. We know in gait the knee is going through internal rotation, and so this popliteus is gunky and not letting us do that. It can affect, just again, like I said, biomechanics of the normal knee, which will prevent return to function. But again, there's like nothing back here anymore. Your biggest complaint right now is going downstairs, right? Loading that quadricep eccentrically, especially because as we're going downstairs, we're, with an upright trunk, we kind of take our butt out of it, so we're forced to rely on that quadricep to control that knee. And again, we had surgery. That thing has to come back, and it's coming back, but strength takes time. And we're going to work on that heel staying down, right? So I'm just going to shift my weight forward, keep that heel down, yep, and I want you to watch that knee. Make sure that thing's nice and straight, yep. Good, so kind of shift back and forth. Good, heel down, gumming that heel, there you go. You feel that the heel wants to come up, but you had to kind of teach it to be down. So give me a good 10. Good, shift and come back. Shift and come back. Excellent. So again, we're doing a re-education piece. We know that soleus eccentrically, grabbing that tibia is what extends the knee in gait, not the quadricep. Quadricep is going to be great for going downstairs, but what we need is that we need that soleus to kick back on. It takes a bit of time to re-educate that piece. You'll see people kind of walk with that knee straight, that knee bent, and it affects their gait. So we want to make sure that thing's getting fully straight. Good. Here, let me give you a stick. All right, we're gonna do steps now. Hold that for me. Go back to feet being even. Yep, so now we're just gonna do a normal step, shift and come back. Boom, little smaller step for me. And I wanna see gum on that heel. There you go. You feel the difference there? That's what I want, yep, good. Think about that heel being nailed to the floor. That's a straight knee right there. That's perfect. Good job, good job. So what I did is I started her with her both feet fixed and just had her drive her pelvis. Now I'm adding a step in. Again, I'm trying to progress towards gait, right? Good. You're fine, you're fine. Awesome. I mean, I don't know if you can see, but I see a huge difference in the ability for her to extend that knee during gait. Like, just good job. Just awesome job. So now we're gonna turn on eccentric quad with eccentric soleus. We're gonna do that little reach we did last time, okay? So come on right here for me. Good job dropping that butt straight down. Keep that toe low. What number is that? 14. Good. I want that hold. That isometric contraction is going to help me recruit all the motor units and just get everything firing. That's perfect. Good job. Look at that. Excellent. Excellent job. Really, really good. Really, really good. You probably couldn't have done this last week, to be honest. Like, seriously, you're getting so much stronger. Yes, please. Yep, so not only working on a little dorsiflexion, we're working on knee flexion, just kind of mobilizing the whole. I'm using a body driver for this. Good. Excellent. Nice and tall. Step forward with that other foot. Good. Tighten the tummy. Nice little, tuck the tail a little bit. Let's push forward. You feel that stretching through there? Oh, yeah, good. Let's kind of move in and out of it. Good. Keep that core nice and tight, that tail nice and tucked. Get a good stretch. Yeah, a little tight. Me too. Good job. Again, our muscles are not lines, right? They have some width and depth to them. So we want to use different planar drivers, like through our hips, to get a bunch of different fibers of that muscle stretched out. If I just do one static stretch and one plane, I'm only stretching out a portion of the muscle. I want to get medial fibers, lateral fibers, everything stretched out. Good. And again, I'm also mobilizing the knee, the patella, and the incision while I do this. Good. Keep that tummy nice and tight. Keep that tail nice and tucked. We should be getting a good stretch through there. Let's do some rotations now. Let's go belly button right and left. Yep, good. Same thing. Just get a good stretch to the front of that. Just twisting. Yep. Again, keep that nice tummy tight. Keep that nice tail tucked. Push those hips forward and just really kind of rotate on that knee. Good. I like how you're standing up and squeezing both knees. Yep, boom, just like that. Excellent. Excellent, excellent, excellent. That's 10. Take a little break. I want another set of 10. We're going to keep bumping your weight up on this. Biggest thing is, so when you put that right foot forward, what it does is it reduces the knee flexion on that right side, and you have a tendency to sit back on your left side, right? So you got to make sure that toes are even, and we're putting a little bit more weight on that right side, like 55-45, to be even. Good, and we only did 6. We went from 0 to 4 to 6 to 8 pounds. Again, we're progressively loading you as you're getting stronger. Looks awesome. Again, this is a post-op patient who I'm kettlebell deadlifting with, right? Because there's no reason I shouldn't be squatting her and lunging her and deadlifting her. And make sure you don't shift off that right foot. Yeah, there you go. You see how your body wants to cheat left? Good job. And again, I'm always increasing load, right? If I leave her at 20 pounds for 8 weeks, she's never gonna get stronger. She's gonna plateau. I'm always trying to push her. That's 10. Take a little break, put it back down, walk it out a little bit. Good job. So the reason I like this also is because as we're getting that knee flexion to improve, the deeper I can load you and the deeper I can get you down here, it's going to require you to be strong in that more bent position.
So this is Aida, and she is here because she has gone through breast cancer diagnosis and a right mastectomy. She also had radiation. How many sessions of radiation again?
33 days.
33 days of radiation. So radiation is generally Monday through Friday. With
15, 20 minutes, yeah.
Yep, 15 to 20 minute sessions Monday through Friday for about the 30 some odd sessions.
Days,
yeah. Yep. And then now she is experiencing, we've treated her in the past for some of the residual scar tissue and radiation fibrosis directly related to the chest wall. Now she's kind of coming back to me because her pain and discomfort is kind of creeping up into her neck on the right. So we're doing a little bit of both, since we know that a lot of the anterior chest wall can then affect posture and neck pain. She does get some kind of arm, kind of biceps pain as well.
Yeah.
Oops, sorry. Yeah, she also is a caregiver for her husband, who requires a lot of lifting and pulling because he has had a couple strokes. So we're trying to make sure that she can maintain that function and that strength that's needed to help him out with his kind of day-to-day life, right?
Yes.
Even though her cancer has been taken care of and addressed, some of the residual effects of chemotherapy and radiation and just scar tissue is unfortunately somewhat lifelong, or I should say more so chronic. So a lot of the times with these patients, they come in for a little while, and then they maybe learn a lot of things to do at home, and then they come back and kind of need a little bit of a tune-up or kind of a maintenance program. So that's what she's referring to, of kind of being back and forth a bit.
Yes.
Yeah.
Exactly. Like I said, it helps a lot. Yeah, so I advise for people with a breast cancer to have regular physical therapy for their mastectomy. You know, whoever have breast cancer, it will loosen you up for everyday work day. You know.
Well, good. I'm glad it's helping so far, but we still have some
yes.
things to improve on,
Yes,
huh?
yes.
Okay. When you're ready, go ahead and lay on your back. So what we're going to do today is work a little bit on, because of where her surgery and radiation is, she gets a lot of tightness through the pec muscle. Her scar runs, I'm going to just show over your gown. Her scar kind of runs from here to here and then into the axillary region too. So you can imagine all of the structures that are in that area and that limit your range of motion, as well as some nerve irritation after both the scar tissue adhering everything down, as well as the nerve damage from radiation too. So we are going to start, I'm going to kind of press along the chest and work on that part first. So we're going to do a little bit of a kind of a pec release, and then we'll kind of work into the whole kind of shoulder and neck area. All right, you let me know if the pressure is too much, okay? So I will get in and do kind of tacking that pec down. And you kind of get a bit of a just general soft tissue mobilization with it. So I kind of tack that pec muscle down and do a pin and stretch type release, adding in. This is where it's pretty sore. Yeah. Usually it gets pretty tight right as it comes and attaches it into the shoulder here. Good. Sorry. Let me know if it's too much.
Pressure, pushing it is good.
Okay. So I like to add, instead of just sitting here and pressing on it, I like to add some passive range of motion to get just a little bit more of a soft tissue mobilization. Doing okay?
Yes.
Good. How has it been doing some of the stuff for your husband?
It's doing good.
Okay.
I said everything came out good.
Okay. I know you've been having some of this discomfort, but how's your neck been lately?
It's everything okay except this one here from here.
Okay, right in the
Middle
back?
of my neck all the way going down here.
Okay.
Yeah.
And that's kind of something that was kind of a little bit more new. We were addressing this mostly, and then it's been maybe, a couple months now that the neck kind of flared up.
Yeah.
So she came back to me to kind of
Yes,
address some of
because
that.
This one here is going to that.
Mm-hmm. Doing okay?
Yes.
Good. Let me know if it's too much.
No, it's like I said, it's really, really good because
Good.
it loosen up, you know,
Good.
the pressure inside. I cannot do it myself.
Right, right. And sometimes we will get in and work with some of the A-stem tools or the cups and do some myofascial decompression along the chest wall, even through kind of the posterior shoulder region. And the radiation, can I let them see this part right here? If you can see here, this is where a lot of her scar tissue comes in. I don't know if you can see that. So you can imagine where this gets really bound down, even as I just do some passive range of motion. The darkening is from the radiation, and then this is part of her scar from the mastectomy. So you can imagine if that's getting bound down against other muscles, even her ribs are right here. And so if that's restricting any of that, she's going to have a loss of range of motion. Sometimes people will have complaints of even having a hard time breathing because they're not getting proper rib excursion. And so we kind of need to address all of that limitation. For her, her neck pain is likely coming as a result of some compensation because of the restrictions in the arm and the range of motion and strength. So now we're kicking in that upper trap. You doing okay?
Yes.
Take a break? Take a break for a second. So for somebody like her, or even other just physical therapy patients, sometimes where their complaints are here, we know that the origin may be coming from restriction that's making this muscle overcompensate. So I usually will address where I'm thinking the primary issue is coming from, and then kind of the secondary pain from some of that compensation. Doing okay?
Yes.
Let's work into that a little bit more, and then we'll go on to your neck, okay? So what I'm doing is just kind of using my thumb and my other hand on top to apply some pressure and do a trigger point release. Sometimes I'll get in and just do kind of your soft tissue or deep tissue, but I like to get into the upper trap with a bit of a trigger point release here.
Yeah, that's part.
That's where it's pretty sore.
Yeah.
Doing okay? We have in the past, we're going to talk about it a little bit more. I'll have to talk to Clayton, Ida, about doing some trigger point dry needling.
Oh.
We did that with, right?
Yeah,
and that really
one.
helped?
Yes, yes.
So that's been something that can be really helpful too, is do some dry needling to that area. We just want to be cautious that we're not super aggressive, just because we don't want to potentially flare up any type of lymphedema. And she responded really well to it in the past, so we may take a look into that in a future session. So I'm just trying to get into this upper trap and loosen it up because it's overcompensating and now it's just really tight. So she gets a lot of tension through here. Hit some of the paraspinals and then get into rhomboids, which are often really tight on these patients, especially with the nature of where the surgery was and the radiation. It often will pull them into kind of that rounded shoulders, and then these muscles get just tight from not going through proper mechanics, and we'll often get little knots kind of right around that medial border of the scapula.
Feels so good.
Good. And the goal is, if we can kind of loosen this up, we can get some better scapular mechanics, which then relate to just shoulder range of motion, shoulder function. And then we'll do some various stretches and postural exercises when we're out in the gym area to kind of follow up with what we've done, but then also hit a little bit of the strength component too. All right, I'll do one last thing. I'm going to reach under your arm here, and then I'm going to kind of just let it just relax for me. And then I'm just going to kind of work on that shoulder blade, that scapular motion. So you just totally relax. Let me just kind of move you around. There you go. So since they often rest kind of protracted like this, I'm going to bring them into some retraction and kind of get into some elevation, upward rotation, since a lot of the times that flexion and abduction become some of the hardest for them. So just getting in with the scapular mobility here. You doing okay, Ada?
Yes.
let's get you moving a little bit with this. So what I want you to do is you're gonna stay like this. You're gonna go from your side here to bringing your arm up and then back down, okay? And what I'm gonna do is I'm gonna reach under and work on the shoulder blade a little bit,
Okay.
okay? So
I don't need to pause for anything, right?
nope, you're just gonna do, we're gonna do maybe, I don't know, 10 of them, give or so.
Okay.
Her range of motion is actually pretty good. She just gets discomfort right at the end range. So I just wanna work with her on that. Overall, now where she's at, she has pretty good functional range of motion. I just like to get the very end range where she has the most discomfort. So you do that, and I'm gonna kind of work under and behind your arm, okay? Go ahead. So while she's doing it actively, I'm gonna come up and give some scapular upward rotation. As she comes down, I do a little bit with kind of this downward rotation, but mostly the upward. You okay?
Yeah, that was good.
Okay.
Oh my goodness, that was so good.
Yeah, let's go up. Good. And you can see a little bit here where she's got a little less motion. You can just almost eyeball it visually there. But that's still really good. It's functional. But how does it feel after working on you?
Tell you the truth, it get looser.
Okay.
You know, get loose than what I normally do.
Less like tightness through here, like where those
Yes,
scars come
yes,
together?
It was good.
Good.
It was so good.
How about if you go down just by like right in front of you and then go up this way? Good. How does that feel?
It's good. Like
Good.
I said, I cannot complain, but
You may still have a little bit of tightness, but we
oh,
know
yeah,
because
you
there's
still
been
have to, like I
sure.
said, but it feels different. Like I
Good.
said, even though I'm doing the exercises
Yeah,
I'm doing,
that's okay. You can
but
stop.
when you stretch it that way, man,
That was a good one.
everything, my muscles in there, whatever is in there, get open up.
Yeah.
You know,
Good.
it feels so good.
So start like you're used to, where you grab on and step through to get that big stretch through the pec. But then I want you to start doing some reaching. Yeah, so you're gonna reach with your opposite arm. You can even kind of get into it this way. Okay, and then open up. It's gonna be a big stretch. So you're in control of it. You just move your arm with what you can tolerate. Okay? Good. Yep, and then you're gonna kind of open up. And you can even use your leg, you can bring your legs together or however if it gets a little awkward. And you can even open your kind of step with it. It's gonna be a big stretch. Good. Woo! Is that okay?
Yeah.
So remember, you're in charge. So if it's too much, then just take a smaller step or don't reach as far. Okay?
10, right?
Yeah, we'll go for 10. So now that we loosened up that pec area, now we're going through some functional movements to kind of gain that range of motion and that mobilization of the tissues as she's going through her own active range of motion. But then we're also getting a thoracic rotation in there. Kind of getting it all going. Doing okay?
Yes.
Good. Do you feel that?
Yes.
Okay. Good. Try to keep those shoulders relaxed. So this is where that compensation of that upper trap we need to get to calm down. So don't let those shoulders inch into your ears. Keep them down and then pull back. So the benefit of this one is it gives a good, you can keep going while I chat, is that it gives a good chest opening and still a chest stretch, but we're also engaging the posterior trunk musculature for that kind of strength and shoulder stabilization too, since she kind of rests in this position. So this is bringing her out of that. So engaging those muscles that just haven't quite wanted to cooperate as much. Good. So really try to squeeze those shoulder blades in the back. Good. Does that feel okay? After 10, take a little break and we'll do another set of 10, okay? There we go. Yeah. Good. So I like this one because it gets in that diagonal motion. So we're working really all 3 planes of motion in one exercise, but then we also got the resistance to work the strength component and endurance component, and it still is opening up that chest wall. So this is a little bit more functional than just doing the one across the chest. So this can be similar to having to reach back and grab like a seatbelt, that type of motion. If she had to reach and grab something for her husband, it's just a little bit more functional than just pulling straight across the chest. Feeling okay with those?
Yes.
That was it? So I like to use the foam roll for some posture, so it's just going along her spine, and then engaged her to get her kind of transverse abdominis engaged, so to flatten the back. She had a little bit more of that lordosis going on, and then now we're working on getting those deep cervical neck flexors engaged, which we know can get weakened with just some neck pain, and just working kind of the postural component. So as muscles in this region either fatigue or get really tight, then we end up kind of with our head forward, and this is kind of getting those to work on some postural awareness with the cervical spine. Good. So this is getting what we just worked on with those neck flexors to now kind of hold and stabilize with some functional movements. Nice. We'll do 10, and then we'll do 10 one arm up, one arm down. But while it's working on the posture of the neck and endurance that way, we're still getting in the upper extremity mobility component as well. Yeah, you gotta try, and it's hard because you're making your brain multitask, and it's doing two things that it's already kind of struggles with. So it's a good way of kind of retraining those muscles. Good. Doing okay? Nice. Oh, shake it out, shake it out, shake it out. Good, you can step away. Nice. Okay, how do you feel?
Good.
Good.
I hope it helps you a lot for this thing, and good luck to your class and your whatever it is, you know.
Well, thank you.
It helps a lot.
You may be a little more sore, especially if we were really making you pay attention to those muscles. So you may be more sore through here. Again, as long as it's like when you leave here and you just got a good workout sore. If you come in next time and tell me it was making your pain a little bit too much, or maybe you got a headache that day, then we know we need to back off a little bit or modify some things. Okay. But I would expect a bit of some soreness.
Yes. Well, like I said, I feel good. Right?
Good.
Listen, everything, you know.
Okay.
So it really,
Perfect.
really feels good.
Good.
Yeah.
Sounds good. Cool.
Yeah.
Very nice.
Well, good luck.
Thank you.
And I hope everything works good.